one of the things I said at Bascom Palmer was, one of my patients going to die in the office waiting to see me at Bascom Palmer. They're here so long, okay? But it's interesting in private practice that in an ownership role with your own staff, you get to do what you think is best for your patients. You don't really bow to
Yep.
administration or things that you think are not important. That's the luxury.
Well, welcome back to the Depths of Healthcare. I'm your host, Ben Imes. Thanks for joining us again. I'm really excited for today's interview. We got Tim Murray on the show today. Tim, why don't you introduce yourself, who you are, where you're from, maybe where you're calling in from?
Hi. So, Ben, thanks for inviting me. I'm Tim Murray. I'm an ocular oncologist and retina specialist in Miami. I was at Bascom Palmer for 20 years before I left into private practice. I have a private practice oncology practice in Coral Gables, which is in Miami. And I'm coming to you from Miami. It's a pretty beautiful day, but always fun to talk with you.
Very jealous of the warm weather you're probably experiencing right now.
Correct.
And now that hurricane season is finishing as well, that's probably very nice for you guys.
Yeah, that's always an exciting part of Miami. California was, of course, earthquakes, and Miami, of course, brings you hurricanes. So life is never boring in the places that I have been.
Never, never at all. You just learn to adjust. So yeah, talk about I think the biggest things that that I want my listeners to hear, obviously you've already touched on, but we'll kind of dive a little bit deeper into those. I mean, academia to private practice, that is a massive shift. I mean, just how you approach every day, right? Touch a little bit on, kind of what that transition was like, what spurred it on, the different explaining your why in a sense and the different things you've learned along the journey.
Well, when I started at Bascom Palmer, I've got to say that I was thrilled to be there. I couldn't imagine practicing anywhere else, and it gave
Hmm.
me multiple unique opportunities. I had an NIH research lab that was looking at children's cancer called retinoblastoma, and I loved teaching residents and fellows. And then I had a big clinical practice. So it was all the things that I would hope it to be. And the people that I was surrounded with were all world class within their own subspecialties. I had a very focused practice and in 2016 I went and got my MBA and I did that with the hope of sort of being more involved in leadership development.
Sure. Yeah.
Hospitals have changed a lot and academic practices have undergone some significant shifts due to a lot of pressures that
Hmm.
are impactful to your patient care. And I live and breathe by taking care of my patients in the OR and in the clinic, and I'm
Hmm.
about advanced technology. And it got to the point where in an academic practice, you have very little say in how your practice runs.
Hmm.
And that became a big frustration for me. And the institutions seemed to shift around me. So I would have to push really hard for sort of patient quality metrics that were important to me and I thought to my patient. And I had an opportunity to look at private practice and I transitioned and I got very lucky. I was able to move a big group of my staff with me and my
Oh
patient.
wow.
It's kind of interesting. I think Bascom Palmer felt strongly that my patients were their patients and I felt pretty strongly that my patients were not going to stay with Bascom Palmer. They were going to come with, and it turned out that I was correct, which was nice. And that I think highlighted, that kind of relationship that you want to have with your patients and their families that you're the doctor. You don't go to Johns Hopkins where I went to medical school. You don't go to the University of California, San Francisco. You go to the world's best doctor that's at that institution.
Right. Right.
That I think is something that people don't really understand. I mean, a lot of people are like, "I wanna go to Bascom Palmer," and I'm like, "No, you wanna go to Doctor
So
X,
and
the
yeah.
best person." If they're at Bascom Palmer, that's great, it's a good fit, but if they're not, that's not the place. So, you go to a doctor, you don't go to an institution. I'm
Hmm.
in school, that's how I was brought up, that's what I believe, and that's how I
Hmm.
continue to practice. When I went into private practice, I was able to really get all the equipment that I wanted. I won't say it wasn't an expensive proposition. I learned how to talk to bankers because I needed to have them assist when I opened my practice, and that was a very different business focus than had ever occurred in academics.
Yeah.
People don't really realize, but in academics, you're an employee. You are not practicing independently. You work for the university. So this was me in my own practice. My staff came with me and they worked for and with me. And we put together systems that really supported the patients. So for example, today we see a lot of patients at Bascom Palmer. It would be like I'd want to see about 85 patients in a clinic day. We saw 85 patients today. I'm already done talking with you, which is amazing. And I would tell you that my patients probably had one of the best experiences today because my staff was clicking, everybody was right on board,
Hmm.
and we were able to move our patients through. In an oncology practice like mine, it's a really complex day. You
Yeah.
come in, you check in, you get evaluated by the tech who measures vision and pressure and visual field and looks at the front of your eye and dilates your eye, measures, the measurements that are necessary for glasses, sends you off, you get wide field imaging photographs, you get OCT, a spectral domain, you get ultrasound, then you come into a room for me, and then most of my patients that we're following have to have some type of therapy. In
Hmm.
retina, that's now injection therapy a lot of the time, and we do a lot of injections, and I have a nursing team that preps my patients for injections.
Hmm.
So we had patients come in where that visit at Bascom Palmer would have taken maybe 5 hours, and they were done in an hour. And if you're a patient, that's a huge difference. I kind of feel it doesn't always impact the doctor because we work the same schedule regardless. But if you're there seeing your doctor and your treatment's incorporated in a 60-minute time frame, that is so different from a 5-hour time frame.
Hmm.
A lot of my patients are older patients. We take care of preemie infants. So I saw two preemies today, and I had two patients that were over 100. So it's a wide range of patients. But
Wow.
you don't wanna be in the doctor's office. One of the things I said at Bascom Palmer was, "One of my patients gonna die in the office waiting to see me at Bascom Palmer because 'cause they're here so long," okay?
Yeah.
But it's interesting. In private practice, in an ownership role with your own staff,
Hmm.
you get to do what you think is best for your patients. You don't really bow to administration or things that you think are not important.
Right.
That's the luxury. Now, what did I give up? I don't have an NIH-funded laboratory anymore doing cancer research because that didn't pass with me.
Right.
We still train doctors, but we don't train I don't train the residents and fellows at Bascom Palmer anymore. I've gotta say I do miss that, but, we have people that come in and train with us here, and I love that because that's a big part of what drives me. I like to be able to give back, and that's one way to give back.
Yeah.
And then when we've pioneered a lot of novel treatments for our patients, and so it's
Yeah.
kind of exciting to be able to do that. And to be truthful, as far as clinical care goes and clinical research goes, it's easier to do that in private practice now than it was when I was at Bascom Palmer. When I
Hmm.
started, all the research was getting done at academic institutions. So
Hmm.
if there was a clinical trial, it was at Bascom Palmer, it was at Mass Eye and Ear at Harvard, it was Wilmer at Johns Hopkins. Nowadays, the practices that are big private practices are easier to get clinical trials through, are easier to get IRBs approved. It's a real change in the world the of practice, and it's changed in my lifetime. I mean, honestly, I've been watching that change. A lot of good things, but, also some things that just aren't quite as good.
Yeah, and that's one of the thanks for that sharing. I mean, that whole journey is just a I mean, yeah, there's pros and cons of every decision that you make, right? But it all comes back to, when do you actually I mean, it's which ones you feel most comfortable living with. And yeah, there's the yoke of taking on the leadership role and being the boss at that point, which can be scary too because when you're going to the bank, you're like, "Don't worry. Don't worry. I'm good for it." But,
Ben, that
but then
exactly right. That was the scariest part of all of this, to be honest, and it still is realizing that I have this huge staff and their livelihood depends on me being able to take care of them. And that is totally different than academics. I mean,
So
academic,
much.
I never thought about the finances. I never thought about, am I going to be able to cover my staff and how do I
Yeah.
handle emergencies? And, there was a luxury in that. You really just practiced, right? If you wanted to go to a meeting, you went to a meeting. You didn't think about what did that mean for your patients while you were gone because there was always somebody that could cover in an emergency. Very, very different when you are in a private practice. And I'm in a solo private practice,
You're still solo.
still solo. And that is I think that's a dying breed in ophthalmology. It's just the pressures for private equity, which you're a little bit
Mm,
aware of, and the pressures for grouped practice, and it's tough to be in a solo practice, but it is also luxurious in that same way. So you're correct. It's like quid pro quo. What do you give for what do you get? And I've got to say, I love my practice, and I love the people that I work with. It's amazing, and that gives you such a joy. My patients are
mm,
like, "How are you always so happy?" And I'm like, this is like a perfect job. And even though there are stressors in the job,
sure. Sure.
it's so outweighed by the things that I get to do. I love it.
I think I mean, I'm gonna highlight that specific part. I think the theme that I'm finding across these different physicians and different businesses that they run, it's really all about the family. It's all about the team that you're surrounded with. And you could say, I mean, those patients could make it to you as we'll call it their second to last endpoint of their patient journey through your clinic, right? Because then they're going to go to get scheduled for their next appointment. And, they've already seen 5 or 6 other employees that you work with every single day. And they're like, "Man, you're so busy. Like, how are you so happy when you're seeing 85 patients in honestly like almost a half day?" And you have to be like, "Because I picked the good people. The good people make it work, and it doesn't feel like work when you're just able to, you know, you're able to have this relationship that's very trusting."
Well, in my practice, what I love too is there's such a commitment from my staff to step up. So, if we are behind in photography, one of my team will say, do you mind if I shoot some Optos images? Or could I tech a patient to get things going a little quicker? Or do you mind? I love that. I love that it isn't, that's not in my job description.
Yep.
Does not exist in my practice. That does exist in academia.
Yeah.
And I
And
never
medicine
understood.
overall.
Exactly, exactly.
Yeah, I just think that's so special. I mean, and you are a very rare breed in that way of also being the solo clinician because then it comes down to the fact that when you have to take a vacation, you got to make sure that everybody can still feed their families. Make sure that the lights stay on.
It's kind of funny too because, one of the things nobody talks about, and even though I had an MBA, I don't think I really understood that, but I had practiced in an academic hospital-based practice.
Hmm.
And I didn't appreciate the differential revenue stream between a hospital-based practice and an outpatient clinical practice, which I practice in now. The same care costs about $2,000 more at an academic center
Hmm.
than it costs in my office. And the costs really are the same, but the hospital-based practices get, a very significant commitment by what they call a facility fee.
Right.
So when I did my business modeling to say, "Oh, how is this going to work?" I thought I was like, this is going to be so easy. And then I got in and realized that the numbers that I dealt with were hospital based numbers, and what I was in was private practice.
Yeah.
And when I had done my modeling for the bank, I didn't model like that. So that was a real eye opener for me. And it still is. So one of the things that I get to do is I'm the editor in chief for one of the journals called the Journal of Vitreoretinal Diseases, which is with the American Society of Retina Specialists. And I get to write an editorial. And one of my editorials was discussing the cost of clinical care in my office versus the cost of clinical care when I was at Bascom Palmer. how different those costs are, but how patients don't really understand that difference at all.
Mhm. Mhm.
And you see that in the ER sometimes where you get a bill from a consultant and the
Yep.
ER team, and there's a facility
Imaging.
for the imaging and the blood work. And, I think it's so convoluted. It's really hard in many instances for patients to understand because they come in to see me and they're like, I'm seeing you, Dr. Murray. Why am I getting 10 bills? Right. And I'm like, That's the nature of a hospital-based practice." But now they come in and it's a single bill and a lot more understandable. Though
Yeah.
it's very interesting. To digress to billing, patients get their explanation of benefits,
Yeah.
and the bill will be like $3,200, and the insurance company will have paid $300. And they're kinda like, "I don't understand," and I'm like, "I kinda don't understand either, but that's the way that works."
Yep. Thanks, insurance.
Yeah, thank you.
I mean, that's like, I think 101, what you just kind of exemplified was, I mean, just those differences of, even just talking about billing specifically. I mean, you could talk about the other things of business ownership that you transition into where, hey, now I'm CEO. Like I have to make, where's our brick and mortar going to be? I have to figure out where we're going to pay rent. Does this space fit all of our equipment? Well, by the way, do we have enough to pay for all the equipment? How is this system going to flow? I think I'm really intrigued to hear, and maybe you can give my listeners a little taste. I mean, you just told us your system and how you're able to see that many patients. I mean, did you come up with that based on what you learned at your academic institution, or just kind of trial and error of, hey, this works better. Hey, this doesn't work as well. How do we shift and make this better?
Well, the world's gotten a lot smoother, I think, in terms of the business of medicine, if you look at it that way. Bascom Palmer, when I left, there was no electronic medical record. It was all on paper. And when I started my practice, I said, "We can't do that." I go, "We are going to start with an electronic medical record." That was a game changer to begin with. So doing that at the
Hmm.
out changed everything.
Hmm.
That was huge. I had you get what they call a practice management software, which is what handles your front and back end for patient scheduling and arrival and billing. And I did well. I lucked into a good system for that integrated with my electronic medical record. And then when I brought my equipment in, I was very focused on making sure that there was good crosstalk. So when you come to my office, you check in at the front desk. That's that practice management software. You're already scheduled, your information gets taken, and you get arrived. When you get arrived, then you shift into a software system that is part of the practice management software that says, here's the patient and where are they going to go. So you started waiting, you go to one of my three techs, you go to one of my two areas for imaging for photography, check, move to an ultrasound team, and then you move into my office. So from the moment you check in, we are aware of where you are all the time. And
Hmm.
then in my office, when you come in, all of the testing that's been done already pops up. I have these dual 42-inch monitor screens, and I can see the pictures of the patients from this visit and the last visit and their electronic medical record, vision, pressure, anterior segment findings. And then we have the opportunity to see what did they look like last time. So if you've been to see me before, I have immediate access to how that exam was. There's no question that your medical records didn't get pulled and we don't know where the chart is. That was such a common occurrence. It was
Wow.
shocking. So now I think that, and how did that happen? I wanted to do that at Bascom Palmer, but Bascom
Hmm.
Palmer wasn't ready to do that.
Sure. That's
So,
it.
and that's okay. Now Bascom Palmer's system looks a lot like my system. Okay. So it's kind of interesting. And, it-
Hmm.
and And I think that by having done that for them a little bit before I left, it kind of pushed them forward a lot faster than maybe that would have happened. But remember, when they chose an electronic medical record, they chose one that helped the hospital. I chose an electronic medical record that helped the patient. They're not the same, okay?
Right.
So my EMR is very, very patient focused.
Okay.
When my patients go, for example, to the emergency room at Bascom Palmer and see a doctor there, they come back and they'll have 32 pages of printout. And
Oh
in
my
those
gosh.
32 pages of printout, there isn't even one page that's focused on the clinical status of the patient. It is all of this stuff that is just maybe important for a hospital, but worthless to a clinician.
Oh,
When
Tim, you're
you
preaching to the choir.
Yeah. When you walk out of my office, you get a 2-page note that tells every single ophthalmologist or other specialist what you have, what the status of your exam is, what your imaging showed, what your diagnostic treatment plan was, and how
Mhm.
you were treated in 2 pages.
Yeah,
So I
it
look at
can be that simple.
it is that simple, but
Yep.
we make it hard. And that's one of the things that was nice for me. I didn't have to make it hard.
Yeah. You just had to streamline it. I mean, you're preaching to the choir when it comes to I just remember, I mean, we get transfer paperwork at our emergency department from all these other kind of rural hospitals and rural EDs, and it comes with a packet that's, that thick of paper, also paper, and you're just having to swipe through all this stuff. I'm like, just give me the lab results, the imaging results, the history, the physical exam. I just need that. Like, what's all this fluff?
Well, where it'll tell you that the patient received an aspirin and all the risks of taking an aspirin and then what the benefits of the aspirin are. And I'm like, that patient's probably taken an aspirin for 40 years. I don't think you need to explain it to them. But I'll tell you one of the things that I found interesting and still is, we as clinicians, we talk to each other, but our electronic medical records do not, right? That's
Mm-mm.
why you're getting a whole slew of paperwork because if you're on Epic or Cerner, which are the 2 major systems
Mhm.
at most of the academic centers and at the VA hospitals, they're not interconnected. So
Right.
they don't talk to each other. So you've
Crazy.
got these companies that are billion-dollar companies who won't let interconnectivity exist because they're afraid from their business stance that it will affect their product. I'm like, what product? You need to take care of your patients. You are impeding patient care, right? And I hate that. I
It's it's one of the worst.
right.
I agree.
It it's frustrating. And patient I don't understand it, but patients don't understand it either. Patients are like, "What do you mean you don't have my MRI scan results?" And I'm like, "Well, you asked it to be sent to me, but it didn't arrive yet." And then they're like, "Well, let them email it to you." And I'm like, "Well, can't send an email, can't send a text, have to send a fax." They're like, "People fax still?" And you're like, "Only in medicine do we send faxes, right?"
It's so frustrating. I mean, on that subject, I mean, what do you anticipate in your field or in medicine overall, whichever you have the better picture of, in terms of where our technological advancements are going, rather than obviously you and I can kind of talk all day about all the issues with the healthcare kind of tech atmosphere. But where do you actually see steps being taken, or you're really hoping that they might get taken soon for my generation and the next generation?
Yeah. So I think that interconnectivity is going to happen. It's just really taking a lot longer than everybody thought. And what you want to do is you want that interconnectivity between your imaging equipment and your laboratory equipment and your medical records so that it's all there. So that's one. And then cross-platform interconnectivity so that if you see a doctor and they're on this platform, their platform should be able to talk to my platform. So it's not printed
Hmm.
and review it. So I think that's definitely going to happen. We're already seeing sort of the impact of AI. I think there's no question that's going to go forward quite quickly in healthcare. And I see a lot of pluses to that, but I also see some areas of concern. So hopefully we'll be smart about how we move that forward. I keep hoping that technology costs come down, but I think that um, healthcare is kind of like the marine industry.
Elaborate.
Yeah, a wrench for a boat is $1,000. Okay, that same wrench for your house is $100. Really? Now you could say, well, it's, a stainless steel marinized version of the tool, but there's really no reason for those major differences. And I think that's the same in healthcare. I think we're inflating costs. I have a camera that I like to use and it costs $150,000. Okay. The
Mm.
entry level of the camera. To make the camera probably costs $1,000.
Woo!
So you look at that and I feel like that camera should be in every office. And if it was $1,000 and it was interconnected, it would be. But it's a big step to buy $150,000 piece of equipment
Yep.
and realize that those equipment pieces, a lot of them aren't able to grow with your practice. So you buy
Hmm.
one and then it outdates the technology and you have to buy another one.
Yep. Great margins, though, on their standpoint.
The margins are amazing. The margins in healthcare are amazing for everybody but doctors.
Exactly.
Doctors get the thing that, you make too much money in the whole bit. I will tell you that of all of my colleagues that went into other fields,
Hmm.
medicine is the least compensated of all of the fields my friends went into.
Yeah.
If you went into equity, if you went into banking, if you went into high-end industry, if you looked at startup. And that's kind of crazy to me because my friends got to start working 10 years before I finished training.
Hmm.
So, you look at that and you think, well, what does that mean? 4 years of college, then you're after college, you do your internship, then your residency, that's another 4 years, then a 2-year fellowship or 3 years, and then you start at the lowest entry level position.
Yep.
Then you work your way up, and usually to end up a full tenured professor at most institutions, it's a decade and a half
Yeah.
after you start.
Yeah. You think
Crazy.
about it like a pie. Have
Yeah.
you thought about it like the pizza or a pie? The pie that you have the ability to produce. So, like, let's just talk about your day 85 patients. That pie is pretty big and pretty substantial. But who takes the biggest chunks out of that? We'll talk about 30%. I mean, you would speak better to the margins and the percentages, but health insurance takes a majority of that, then the imaging and the rent, and then this, and then employee pay, and then you get the breadcrumbs after everybody else has been paid.
Well, that's the thing and that was the hardest thing for me. And as a business owner, I realized that I had to pay everybody else first.
Mm-hmm.
And then what was left over, that was going to be what I got paid. And that could be a lot different from what that was. So you look at your billables and then your collectibles and then your overhead costs and your staffing. And when I went in, I wanted my staff to have good benefits. So we have an amazing benefit package. So I wanted
Mm-hmm.
good health care and,
Yep.
I wanted eye care and dental care and all the things that you would hope for, not realizing that most small businesses really don't do that
Right. They're
because
kind of off on your own.
yeah, because it's crazy expensive. My luxury was that I didn't have a big startup because my patient base came with me,
Right.
huge. And then what I love is I joke with my patients. I have some pretty wealthy patients and I have some pretty not wealthy patients. Yeah, my patients are always like, "Wow, I wish you had an office in Naples." And I'm like, "Yeah, it cost about $5 million to start this office. Well, I'm not thinking I want to start another one." And then I joke and I go, just the back and forth trip, and if I had a helicopter, and then one of my patients is like, well, how about if I build you the office and you use my helicopter? And I'm like, no, no, I really didn't mean it. Oh,
They're like, oh, I'll take you at your word. So you just tell me more.
exactly. But what you realize is that that's such a small part of everything. My staff reproducing a staff at this level in this kind of complexity of practice, that it's easier to build the office and put the equipment in and put the records in than it is to find really amazing people at the level that they practice in my office. So I'm always backpedaling. So I don't really tell that story anymore with the caveat if somebody wants to do that.
Right.
But it's amazing. It all comes back really to what you said at the beginning. If you can work with people that you love to be with, that's the game changer. And when the fellows that have finished their training are looking for jobs and they're asking me, what do you think? I'm always like, find people that you feel that you can work with and be with, because that's more important than is it Bascom Palmer? That's
Hmm.
more important than is it in New York City? I
Or
mean,
the paycheck, even. It's more
or
important than
even
that.
the paycheck. That is correct. And when I started, my fellows would never have taken the job I took. My paycheck was so small because I was so happy to go to Bascom Palmer. And, I almost didn't get to go because during the interview process, the chairman of the department said, well, do you have anything you're unhappy with? And I'm like, I really don't want to come to Miami. Okay. Because I mean, Miami in the early 90s wasn't the place to be.
Yep.
So, and he was like, what? And I go, if you were maybe up in, the Northeast, maybe that would be a little easier for me. So, and then to be truthful, you don't know what you don't know. I love Miami.
Okay.
I have fallen in love with Miami. I came here, I bought a sailboat, I lived on a sailboat. My
Nice.
chairman also was like, boats are good, but not to live on. You should have a place on land. It's kind of fun to see what you can do.
Yeah.
And the idea for me was, always patient care first, and then always about trying to have the best equipment and the best ability to take the best care of our patients. I'm, 30 years into this, it's still about that. That is
It's
what.
all that matters.
Right. And then one of my true pet peeves, of course, is when people tell me that I need to take better care of my clients. So one of the hospitals called me and asked me, what do you do for client care? And I was like, what? You mean patient care? And then they go, well, then they did the healthcare provider. And I'm like, no, no, I'm a doctor. Okay. I am not a provider. So, I mean, the language has changed also
It's true.
around this. And it's so different, right? I mean, I can't imagine thinking of my patients as clients. I can't imagine thinking of myself as a provider. That's very different than how I kind of define myself. Very interesting
Right.
change.
Yeah, and I don't know if it's all for the better in that category, specifically what you're talking about. Like, I'm very much aligned with you in thinking that there's a great defined role for AI in how it helps practices optimize, even just dictations or note taking. I think the cross connection between medical records would be very helpful. That should have been done 15 years ago, but here we are. But yeah, the lingo is changing and people are expecting different things. And it's interesting when I have a patient show up and they're like, I don't want to do that scan, even if they're writhing in pain and their belly is hurting. And I'm like, well, you might have just perfed your appendix. Like, don't you want to figure that out? They're like, well, you're going to get $3,000 off this. I'm like, let me show you the pennies that I make off of you. But it all comes back to providing good patient care because I care about you. I'm in front of you. I want to take care of you. That's what I was trained to do.
And it doesn't mean that, I think I'm very cost effective. So one of the things is that we do these injections and there's different drugs that we can inject. And some of the drugs are very inexpensive and some of the drugs are very expensive. And
Hmm.
you want to use the best drug for your patient. And I'm very believing that you should be able to personalize medical care to
Yep.
the patient in front of
Yep.
you. But at the same time, I think most of our doctors and I am the past president of our big society. I think people are thoughtful about what they do. And I really don't see doctors that do something because it's a monetary incentive. So let me tell you, if you want to make money, you don't want to be a doctor. There are
Yeah,
better ways
exactly.
to do it. Okay.
Yeah.
So and honestly, you don't see people practicing through time unless they really found a way to practice well where their patients have that kind of rapport with them. I like to explain every test we do. So when you're in your office, I look and I love it because like even today, I get patients that come in, sit in the exam chair, they've had their imaging, they look up at the screen and they go, oh, and I go, what do you mean? Oh, they go, well, I have macular edema, so you're going to inject me today.
Mhm.
I go, that is correct. I have patients that can interpret an OCT better than some of the young residents
Wow.
in Palmer because they come in, they have high technology use, they're able to see, and it has direct impact on them. They
Yeah.
know why that's important.
Yeah.
I love that. I think that's really kind
It
of
would be it has them they're bought in at that point. Like, they know their body, they know their healthcare, they can explain it. Let's say this your 100-year-old patients can explain it to their grandchildren
Yep.
and
Well,
say, "I've
maybe
got
not my
flame hemorrhages."
100-year-old patients. That's a lot of technology when you're a century old.
Oh, yeah. And they're like, I've got flame hemorrhages on my retina,
I
and
know.
this is how I'm getting fixed." And they're like, even their grandchildren are probably like, "I have no idea what you're talking about, grandma."
Yep, exactly. Until they realize that some of these conditions are hereditary, and then they're like, "Can I come see you?" And I'm like, you don't really need to worry yet. You're only 20, but you can have an appointment, and we can look for some of the precursors of this.
Let's set the baseline.
And then the other thing that's kind of cool is how much genetics is evolving and how a better understanding of genetics is going to allow better targeted care. And then you saw that where we've had a chip for the eye for a long time. It was developed by Mark Kumayan at USC. That chip isn't even made anymore, but the next generation chip looks amazing, but the manufacturing tolerances are not great yet. So we don't have that chip. But then you look at Elon Musk with a Neuralink chip, and you realize we're right at the cusp of some amazing technology shifts that are going to benefit people. I look at my patients that don't see, and I go, if they're young, I go, in your lifetime you're going to see again. I can't tell you if it's going to be 5 years or if it's going to be 25 years, but it is going to happen. And
Yeah.
then, for example, macular degeneration for our older patients, when you develop advanced macular degeneration, that was untreatable. I hated disease. When I started, I didn't even want to see macular degeneration patients because all you did was watch them slowly deteriorate until they had lost their central vision.
Mhm.
Now with injection therapy, you can get vision back. And if
Right.
you start treating, usually I love this. There's a paper that's going to come out in the journal next month. And what it says is that if you're already seeing a retina specialist and something bad happens to your second eye does great. And that's because we're already looking at you. And
Yeah.
when we look at our patients, we don't look at one eye. We always look at both eyes.
Always. Yeah.
Always. And so I look at that and I'm like, in my lifetime, the advent of this pharmacologic therapy has changed everything.
Mhm.
And and then to do that, to make it really work, we had to get the imaging to work. And that the OCT technology, which is that optical coherence tomography, it looks at the eye like you're looking at a histopathology section in the laboratory under high magnification. I look at that, I tell my patients, nobody could ever see this before.
Mm.
Now I can see it. That's what we follow and target for your treatment. And now I have
Mhm.
that allows me to treat you. I go, that's
Yeah.
just the tip of the iceberg of where I think technology and medicine is going to go, at least in my field, over the next decade.
Yeah. That's really, really exciting stuff. I mean, you've talked about where your field is gonna go. Now let's narrow it down where you and your practice are gonna go. I mean, what do you have planned over the next 1 to 2, maybe 5 years, kinda to of an idea?
Well, one of the things is we've made big commitments into technology. So that's an expensive thing to do, but for me, that's how I want to practice. I don't want to be at anything but the cutting edge of the technology that allows me to
Mhm.
care of my patients. I'm a little old fashioned. I use nurses in my injection prep, and
Mhm.
I mean, one of the few people in the country that still do that, and it's expensive, but I'm kind of like, this is a mini surgical procedure, and that's what nurses or surgical techs are trained to do. So I think that I know that AI is going to get a huge benefit. You know that there is technology now that listens to the exam room and records
Yep.
everything that's said in the room and
And
transcribes.
condenses it.
Yeah. And I look at that and I'm like, I feel like we know that when a patient comes in the room and you talk to them, that they maybe remember 40 to 50% of what you said. That's so inadequate, right?
Right.
So if the patient can come in, and I don't mind at all. I have patients that'll come in and say, "Can I record our visit?" And I'm like, "Of course." You know,
Please do.
please, because that way you're going to know exactly what I'm saying, and you're going to have that to be able to go back to. But I think that's going to be a huge advance for us. I hate AI when patients go to AI and ask it for diagnostic issues, because
Yeah.
what happens is they come in and they're like, "Well, what about this treatment?" And I go, "Well, you don't even have the disease that treatment targets." So it's fascinating, but it's not relevant to you. Now, as AI becomes better and more personalized, I think maybe that will shift. But right now it's like Dr. Google, right? I'm always sad when my patients that I'm a tumor specialist, so they get told they have a tumor, or they go to Google, and patients come in thinking, I'm going to die, I'm going to have my eye removed, and I'm like, well, the good news is you're not going to die, and your eye's staying in your head, so that's good, and that's why Google is not the best doctor for you for right now. I go, but I'm a big pusher about write your questions down. Do you
Yeah, definitely.
know what to ask your doctor when you're there? The visits are fast, but I'm like, I tell my patients, I'll never walk out of the room if you have a written question that I haven't answered, ever.
Right.
Okay.
Right.
But like my mom was famous for going to the doctor, forgetting every question she had while she was there, walking out of the doctor's office and calling me and saying, what did he say? And I go, Mom, I wasn't even in the room with you, so I have no idea what they said. Did you write
Good.
the questions down? And she's like, you tell me every time. And I'm like, yes, I do. There are so many exciting things. In my field, one of the big things is the consolidation of practices with private equity.
Right.
That is a game changer. When that started, I was really opposed to that because it changes that model again, and ownership shifts and ability to focus practice shifts. But there are a couple of these large private equity groups that have done a really good job with this, and they've focused on advanced research and clinical care, things that I think are exciting. So my initial private equity is bad thing is mitigated. I think there's good private equity and there's bad private equity. And then you have hospitals acquiring practices.
Hmm.
I think that I'm less focused on that as a model when you're an outpatient practice.
Yeah.
So it's healthcare is changing, and we're going to all have to change with it. And hopefully we can focus those changes in a positive way. So for me, when I bought this practice, two things I did that most people don't get to do. I bought my office, so I didn't.
Hmm.
That was I mean, if you want to talk about what my
That's a big commitment.
but my retirement profile is my office. My
Yeah.
makes more money accumulating in Miami real estate than I make as a doctor. It's
Totally.
crazy. So there's that. And then the second thing was that I built the office with enough space for another doctor. So ultimately, I'd love another doctor, but not everybody wants to practice like I do. So,
You
so
can be picky though.
I
You can be.
and I have been, and that's why I'm still in solo practice, because I'm picky.
That's okay though.
My problem was that we were talking about family. So I have two daughters, so I'm very girl focused for empowerment. My oldest daughter is graduating from college, applying to medical school, and my wife's like, just let her join the practice. And I go, hon, she hasn't started medical school yet. Okay. Do you realize that we're talking about a 10-year journey at the shortest? So that means you want me to practice for 10 more years. And she goes, yeah. And I go, and she goes, You got to do what you got to do for your girls. And I'm like, okay. So who knows?
If you put that before it, it makes sense. But also, you're like 10 more years of this. I don't know.
Well, it is true that I really love it. I think the
Yeah,
harder
yeah,
part
yeah.
now is that, I have a surgical practice. And so I have to go to hospitals, and I go to a really ritzy, expensive hospital. And I go to a really not ritzy, not expensive community hospital. And that way my patients across the board have access. But it is getting harder and harder and harder to get patients into an operating room
Hmm.
as a retina specialist. And it's kind of short-sighted, I think.
No pun intended.
No pun intended. That is correct. So I'm interested to see how that's going to play out over time and what
Yeah,
that's going to mean. There's some talk about operating in an office doing
sure.
based surgery. My plastic surgeon colleagues do that all the time, really.
Hmm.
But for my specialty, it's really not been done.
Hmm.
Sure, I do it? Yes. Do I want to do it? I'm not sure. So there's things I'm looking at trying to see how does that work best for this.
Yeah. So we'll see. We'll keep updated kind of with how things can continue to progress, I guess.
Yeah, absolutely.
Where where can my listeners kind of see what you're doing and kind of track along? Like what are the best mediums or platforms to kind of follow you?
So to follow me, because of the things I do with the journal and with the ASRS, you can see some of my very directed podcasts on YouTube. That's one place to go. I think the American Society of Retina Specialists webpage is one of the best web pages to go to for that. And then, we're blessed, at least now, and it may change, to have the National Eye Institute, which is one of the sections of the National Institute of Health. They have some great information there for that. So I think there's good information.
Hmm.
It's getting easier and easier to find. So that's where AI can be helpful. So if you say, to chat GPT, I'd like information on macular degeneration from the ASRS and the NEI, it will give you that information. And then
Right.
if you're really nerdy, like some of my patients are, you go to PubMed, right? And if you want to read the original source material, so in PubMed, which is the National Library of Medicine, you can type Murray TG and my 500 papers will pop up. And trust me, you can die of boredom reading all that stuff.
It's almost like water boredom.
Exactly.
That's my new dad joke. That is fresh off the top just because I have a small child at home now. I'm learning these, as I'm sure you've practiced for 20 plus years.
And two children teaches you even more. So Ben, you are on the learning curve right now.
We're doing it, man. Well, Tim, thanks for your time today. Thanks for sharing all your insights. I'm really excited for my listeners to get access to kind of just peeking inside your brain and, for lack of a better way to say it, seeing through the eyes that you see medicine now and being able to kind of take a look at the world from what you've seen transition over your career.
Well, thanks for having me. I think it's an incredibly exciting time, and I've been blessed to practice in a time that's been changing rapidly. And I'm excited about what the next decade's going to bring.
Super excited to see what happens. Watch this space, listeners. Watch this space. All right. Thanks, Tim. You have a good one.
Thank you, Ben. Pleasure.